introduce you first of all myself. I'm Nikos Karavidas. I'm a physiotherapist from Greece, the founder of the PSSE-Schroth method, and we will present this webinar together with my colleagues, Burcin, Serinturk, our instructor from Turkey, Sarah Mohamed Ali, our instructor from Egypt, and Georgiana Cojocaru, our instructor from Romania. The webinar agenda is the following. So we'll start with an introduction from Georgiana about conservative treatment of scoliosis, history of Schroth method. Then we'll have an introduction to our PSSE-Schroth method and the reasons that someone would like to be educated in our school. Then we will discuss about our classification. So we'll have 5 lectures. And then we have allowed plenty of time to discuss any questions that you have. Then the second part, we'll go to a little bit more practical with the 3D principles of correction for our school and the exercises. You'll have some demonstration about this, and then we'll speak about the bracing and how our classification can be used for brace design. We'll show you the scientific evidence so far, also some studies from our groups and treatment results from the technique that you're going to see in this webinar, and the educational plan and future courses in Asia. And then we have a brief wrap-up and conclusions, and then again, plenty of time for discussion. So now I would like to give the word to Georgiana to start with her presentation.
Thank you very much, Nikos. Hello, everyone. I hope my sound is okay because I'm trying to talk on both applications. Perfect. Just a second to share screen. Okay. Can you tell me if it's okay on Zoom? And vous, vos all?
Yep.
Yeah, perfect. Thank you. Yeah, it's okay for everyone, yeah? Okay, hello everyone. I'm Georgiana Cojocaru. I'm the instructor of PSSE-Schroth method from Romania. I'm a physical therapist since 2016. I have my own clinic in Romania, and I'm working most of the time with scoliosis patients. Now I will start to talk about conservative treatment of scoliosis and also about history of Schroth method. So what is scoliosis? Scoliosis is a 3D deformity that affects the body in all 3 planes: frontal, transversal, and sagittal plane. The scientists have tried with all their efforts to find what causes the scoliosis. But at the moment, we don't know the cause. We don't know what it appears. But we know that it's called idiopathic because, as actually I said, we don't know the cause, why it appears. And here we have some definitions from international societies. The Scoliosis Research Society defines the scoliosis as a lateral deviation of the spine with a Cobb angle greater than 10 degrees with rotation for unknown reason. The second definition is from Society of Scoliosis, Orthopedic and Rehabilitation Treatments, and defines the scoliosis as a complex 3D deformity of the spine and trunk that appears in healthy children and can progress in relation with multiple factors during rapid growth periods or later in life. So how can we check if we have patients, if we have scoliosis, if our patient has scoliosis? At the beginning, it's important to start with a clinical evaluation, and the most important tools for us is Adam test and the scoliometer value. We ask our patient to bend forward from standing or from sitting if we suspect that our patient has length discrepancy. And the scoliometer will be at the highest level of prominence, and the value will show us the angle truncal rotation. Initially, it's important to start with this clinical evaluation, but with Adam's test, but we have a lot of tools that we are using for clinical evaluation, like history, questionnaires. We measure the patient height, weight, and then if we suspect that our patient has scoliosis, we have to send him for an X-ray. If our patient will do an X-ray, we have to see on X-ray a Cobb angle more than 10 degrees with rotation. The most important is that on this X-ray, we should have a complete curve. What means a complete curve? That we should have two vertebrae, both tilted in opposite, in the horizontal plane. Then, if we have scoliosis, we have to treat our patients. And here, for treatment indications, we have guidelines from Society on Scoliosis Orthopedic and Rehabilitation Treatment from 2011, which recommend physiotherapeutic scoliosis-specific exercise for patients with Cobb angle between 15 and 20 degrees. And the research stage at 0 to 3, braced patients regardless of the Cobb angle, patients with a Cobb angle between 20 and 40 degrees at the end of skeletal maturity, research stage 4, 5, adults with any Cobb angle who experience pain. But in our method, in PSSE-Schroth method by Nikos Karavidas, the recommendations are slightly different. Nikos recommends scoliosis-specific exercise for scoliosis with a Cobb angle even less than 50 degrees or 10 degrees if our patient has positive Adam test that indicates us a hump on one side, so it may suggest potential progression. We can work also with adults these exercises regardless of the pain because we can improve aesthetic or we can stop progression. So what is PSSE, physiotherapeutic specific scoliosis exercises? These are regarding to Saussure are the first step to treat scoliosis and prevent progression or bracing. These exercises are based on 3D autocorrection, activities of daily living training, and stabilization of corrected posture through patient education. PSSE should be designed only by certified physiotherapists. Individualized program according to curve type and patient's needs and treatment phase. In this team should be also always a medical doctor, a physiotherapist, and an orthesist. So for working with patients with scoliosis, we need a multidisciplinary team. Bracement treatment should be accompanied by PSSE, and sport activities can be considered as alternative, cannot be considered as alternative treatment. So yes, we can recommend sports for our patient, but not as a treatment. And it doesn't matter what kind of sport. It's important just to do some movement sports our patient with scoliosis. About Schroth method history, We know that it was developed by Katerina Schroth. She was born in 1994 in Dresden, and she suffered from scoliosis during adolescence. She tried to correct her posture by observing herself in a mirror. She was comparing her thoracic cage with a balloon, and she tried with her breathing to correct herself. And she and the people around her saw that she has improvement in her trunk appearance. So in 1921, she started to work this therapy with patients. So she founded the first Schroth Institute called Breathing Orthopedics in Meissen, Germany. In 1961, Katerina and her daughter Krista moved to Bad Zoberhem, and in 1983, they established their own clinic. The name was Katerina Schroth Clinic. Katerina died in 1985, and Krista continued her mother work, and she refining the orthopedic breathing treatment. Krista retired in 1995, and her work was continued by her son, Dr. Weiss, a medical director at Asclepius until 2008, with Dr. Manuel Rigo and the physiotherapist Axel Hans. In 2019, these three decided to split and develop their own methods based on their individual ideas and their philosophy. So from 2019, we don't have original Schroth method because they divided, so they made their own method. Axel Hans has Schroth ISST, Manuel Rigo has BSPTS Rigo concept, and has Hans Rudolf Weiss, which is the son of Krista Schroth, has Schroth best practice. In 2022, Nikos Karavidas founded the PSSE-Schroth method, and this one is the newest development in the field. But now I will give the word to my colleague, to Burcin from Turkey, to talk more about this method. Thank you.
Hello, everyone. I need just 1 minute to set something. Yes, great. Everything is okay with my sound because I use two applications at the same time. Everything is okay with my sound? Yes, perfect. Okay. Now I share my screen. Now you see my screen in both applications. Okay, great. Again, hi everyone. I am Burcin Serinturk from Turkey. I had been an instructor in PSSE-Schroth School for 2.5 years. I am physical therapist for 2017. And today I'm going to talk about physiotherapy scoliosis specific exercises, PSSE-Schroth method, and what is PSSE-Schroth method and how the method was born. Yeah, as you may all know, Nikos Karavidas is the founder of our school, and this was his educations. and he has completed so many scoliosis-specific schools. And since 2017, he was Rigo Concepts teacher, and he gave more than 40 courses in the next 5 years until 2022. At that time, he decided to develop all his own school, and we have officially started at 2022. But this is not something new for Nikos, because Nikos used to work during all these years with all these ideas at his own clinic. So this is not something new for Nikos, but let's say we have an official start at 2022. And what is PSSE-Schroth method? PSSE-Schroth method, we have a program of physiotherapy scoliosis specific exercises. We are working with scoliosis and kyphosis treatment, and the all concepts acquired by clinical experience, and we are based on original Schroth principles. We have some adaptations from other PSSE schools, other scoliosis specific schools. Nikos' ideas at the first, keeping their advantages, try to keep their advantages and try to improve their limitations, and of course adding some new idea, adding some new idea, and this idea of course from by Nikos to the field. And we have new curve type classification, and we have new ideas for 3D correction. Now the slides, I try to be short, I won't be too long, but I just want to give you an idea the limitations and the advantages of other PSSE schools. This slides does not mean criticize any schools, because we all know that all these schools are proven that they are effective in scoliosis treatment. I just want to better understanding to you how our method was developed. So I want to do this introduction. Let's start with the BSPTS Rigo concept. They have high quality theoretical education, and they have simple clinical classification. They have 4 main types, and they have really nice radiological classification for the braces. When we check the potential limitation, they have too long educational plan and no variety of exercises and low potential for overcorrection. What is overcorrection? You will see these later. And they have online basic course without an instructor. And the next one, Schroth ISST, they have easy practical application from patients, and they use overcorrection in specific curve type. They use mobilization, and which is really important scoliosis treatment, and they give attention activities, daily living training. And when we check the potential limitations, they have some difficulties in classification of double curves or the balance curve. And I think the most important one is they miss one curve type, and you will see very common in the field this type, lack of one curve type in clinical classification, and this curve type not rarely type. This is very common. You can see very often, and they have some difficulties in practical application in double and balance curve, and they have some risk of worsening secondary curves by overcorrection of the main curve, because overcorrection, you will see what does overcorrection means, but overcorrections brings with it some problem, for example triggering the other curve or creating the new curve. So there are some risk of worsening secondary curve. When we check Schroth best practice, is application for mild curves, and they use
Burcin,
specific types.
Burcin, sorry to interrupt you. If you can just minimize a little bit the side with the names of the participants, because some participants, they say that they cannot see the full slide. That's perfect.
Okay. Great.
Now it's perfect. Thank you.
Okay. Let's continue with Schroth best practice. They use maximum overcorrection in specific types, and they give intention activities of daily living training. And what is their limitations? They have short total education, and same with ISSD, they have risk of worsening secondary curves by overcorrection of main curve. As I said before, overcorrections brings with it some problem, and no variety of exercises. And they have some difficulties for double curves, especially for the balance curve. And when we check Lion method, they have really nice, high quality theoretical education. They use a lot of mobilization, especially in the lumbosacral area, which is really important in scoliosis treatment. They use sagittal plane correction, which is really important, and they train activities of daily living. When we check the limitations of Lion method, they have short total education, just 3 days for total, and absence of practical education, and no variety of exercises. And the Lion method is less scoliosis specific method compared to the other schools. When we check the SEAS method, it's easy application for mild curves. They use some dynamic exercises, but when we check the limitations, short total education, 6 days in total, and difficulties for double and the severe curves, and they do not use any kinds of mobilization, and these can be potential limitations. Let's go to our school. What is the advancement in classification of PSSE-Schroth method? I want to start with classification because we have new developed classification, and it is easy and accurate classification, and you can describe all the curve types by just answering 3 simple questions. And we all know that classification, the role of classification is too much, because the role of classification is not just to say this is one classification and this is another classification. We need to give the proper information to the therapist on how to accordingly treat their patient, which is really important. We introduce you concept of overcorrection. You will see overcorrection concepts later. How, when we use overcorrection, when we shouldn't use overcorrection. The decision of overcorrection is based on clinical, radiological, and prognostic criteria. And our aim is to get maximum correction for curve types when recommended, and at the same time avoidance when it is risky for creating compensation. Because as I said before, if you use overcorrection in every time, every exercise, during all session, it brings with it some risk, like creating compensation or triggering the other curves. But in our classification, in our method, we do not take risk to create any compensation or trigger the other curve, because we do not accept to sacrifice other curve in order to correct main curve. But at the same time, we do not miss the opportunity of the reaching best correction to the main curve. You will understand me later. And sometimes it's hard to choose classification. You will see also by your experience, sometimes it's hard to say this patient is this classification, because sometimes you will face some dilemmas, and just not only just classify, and at the same time how to treat your patient. But I can tell you, in our method, we have some advancement in classification, especially we have some advancement how to classify our patient and how to treat our patient. For example, if we have curve, balance curve, thoracic and lumbar are balanced, or if we have pelvis is more or less balanced, or if we have thoracic curve, but we are not sure whether is structural or not, or if we have thoracolumbar curve with the apex T12 L1, you will learn how to manage this kind of patient, and you will learn how to apply the method on this kind of patient. When we checked our educational plan, we have proper duration for education. We need 3 days for basic course and 6 days for level 1 course. and in total 9 days to start applying the method in every curve type. To get final certification, you need 15 days. We offer the opportunity of basic course online by live teaching on Zoom, but with an instructor. And what you mainly see in our basic level, clinical assessment and prognosis and radiological measurements and pathomechanism and progression and many other things. And at the end of the basic level, you will have evaluation form, and it's developed by Nikos Karavidas. We have unique patient evaluation form for clinical and radiological assessment of patient with scoliosis and kyphosis also, and it makes easy to evaluate your patient. When we check advancement in practical application for our school, our aim treats our patient precisely and safely to get maximum effect of exercise based on our classification. And we have new concept for 3D correction, and we have new terminology. We have new ideas for corrective and rotational breathing, and we have new techniques for muscle activation. We have new concepts of activities of daily living, but of course based on our classification. But at the same time, we have selective overcorrection for specific curve types. And at this point, I can tell you that our school seriously stands out at this point, because we will use overcorrection and we will use overcorrection, selective overcorrection in specific curve type. Our aim to avoid creating any compensation or triggering any new curve, and at the same time, our aim is to get maximum possible effects, reaching maximum possible effect for the curve. We don't want to create any compensatory curve. We don't want to triggering any curve, but at the same time, we don't want to miss the opportunity to reaching maximum effect. We have new exercises, and we have different execution of already existed Schroth exercises, but based on our classification. We have new mobilization, new ideas for the mobilization, and we will use combination of corrective breathing with mobilization. We will special emphasis on proximal thoracic scoliosis because the physical therapists working on this field are concerned about proximal thoracic scoliosis every time, because proximal thoracic scoliosis, it's hard to manage, it's hard to affect because it's too high. I mean, it's more difficult than the others, but with our method, you will learn how to affect proximal thoracic scoliosis, how to apply the method on this kind of patient. You will learn this. And we will talk about too much thoracolumbar curves because sometimes thoracolumbar curves can be confusing by the therapist, but we will manage this kind of process. And I can tell you that proximal thoracic scoliosis and thoracolumbar curves are no longer concerned after PSSE-Schroth method. This is really important for all the therapists working in this field. And we have large variety of exercises for kyphosis and scoliosis. Now I give the word to Sarah to start her own lecture. Thank you. Now I stop sharing my screen.
Hello, everyone. Just a second to share my screens on both applications. I'm already sharing in my Zoom. Just 1 second. Can you hear me well now? Can you hear me well in both applications? Because I can see. Can you hear me well? Okay, I will start. Hello, everyone. My name is Sarah Mohamed Ali. I am instructor of PSSE-Schroth method, having a master's degree in orthopedic physiotherapist, and I have been certified in many other schools. I've been working with this since 2019. My introduction today about the PSSE-Schroth classification. Okay, so I'll start with the principles or the questions that we ask ourselves for the PSSE-Schroth classification. So first, the first question we ask, do we have a structural thoracic scoliosis? We do. In order to answer this question, we need to do the forward bending test and to check if there is a hump or not. If yes, there is a hump, we ask ourselves the second question, where is the pelvis in relation to the trunk in the frontal plane? Okay. The third question, is overcorrection allowed for the main curve or not? Okay. So, second. Okay. The first question, we answer this question by doing the forward bending test clinically. If, for example, I have a right thoracic curve, I need to confirm if this is a true scoliosis or not. I do the X-ray, my X-rays. When I do the X-ray, I found that there is a rotation of the pedicles and of the vertebra and the pedicle, which means that there is a true scoliosis. Okay. The second question is about the pelvis position in relation to the trunk in the frontal plane, and the third is about the overcorrection. In order to know the third question with the overcorrection, just 1 second. We need to answer first, what is an overcorrection? Where is my main curve? And if I can do overcorrection or not. In our classification system, we have a clinical, radiological, and prognostic criteria to follow the overcorrection of the or not. For example, in my clinical criteria, if I have a severe rotation, if I have a frontal plane asymmetry, pelvic tilt, it means like the pelvis is elevated on one side or not, the significance of the structure, curves, and rigidity. These criteria all together, or maybe one of them or mixture of the criteria can lead to can make me want to decide if I can do overcorrection or not. The second is the radiological criteria. It depends on the cup angle. If my cup angle is severe or not, the axial rotation, the vertebra deformity, or the structural changes on the vertebra, the Reser stage, the frontal plane asymmetry, the transitional point in relation to the central sacral line, the significance of the curves, and the end-brace correction. The third is my prognostic and other criteria, the risk for progression. The higher the risk of progression, the more that we can sometimes change our decision to do the overcorrection or not, if there is a pain or any changes in the cosmetic issues. All of these together, we do the data analysis and synthesis based on the patient history and everything we do in the assessment in order to decide if I can do an overcorrection for this patient or not. So what is overcorrection? What is the definition of overcorrection? In our school, we have normal exercises and we have overcorrective exercises. The normal exercises that we do is like we have the patient having scoliosis and we put this patient in a perfect 3D alignment. This doesn't mean an overcorrection. We do correction of each and every curve in order to have the patient well aligned. This is the normal exercise. How about overcorrection? In our school, we define overcorrection or overcorrective exercise when we allow lateral flexion. It means that we put the main curve into the maximum correction. Okay, so now just to summarize it, that we have a normal exercises and we have overcorrective exercises. In normal exercises, like the exercise on the below on the side lying, we have correction of the curves, of the main curves and the other curves, but not allowing for the lateral flexion. So this is a normal exercise. But in the other exercise, like the mermaid here in this picture, we allow lateral flexion. It means that we allow the maximum correction for our main curve. Okay. Second, we have an overcorrective techniques. Overcorrective techniques, it could be applied and it could be applied in the normal exercises and in the overcorrective exercises. In the normal exercises, we play with we correct the some pelvic corrections, frontal and transversal plane corrections, and lateral flexion in case if I'm doing an overcorrective exercise. Okay, we have many curve types, around 8 curve types that will be explained next in the next slide. But we have introduced also another terminology which is the selective overcorrection in the plus type, that we don't allow overcorrection. Even in the plus type, we don't allow overcorrection in all exercises. We decide based on each patient individually and based on the clinical criteria, prognostic criteria, and radiological criteria. Okay, so to start with the PSSE-Schroth classification, we have in the sagittal plane deformity, talking about the kyphosis, we have a thoracic kyphosis, thoracolumbar kyphosis, and lumbar kyphosis. Okay, the second types, it's related more to the scoliosis. So if we follow the 3 questions that we introduced them, where is there a structural thoracic scoliosis? If yes, if I have a structural thoracic scoliosis, how can I see this structural thoracic scoliosis? I will ask the patient to bend forward to check if there is a hump or not. For example, in this picture, we have a right thoracic scoliosis having a right hump. Okay, so the second question would be, where is my pelvis in relation to the trunk? I have only 3 possibilities. Either the pelvis would be to the right or to the left, or will be in the middle. Okay, if I have the pelvis to be shifted to the, for example, if this a right thoracic, if it's shifted to the left, okay, toward the thoracic concavity, we call this type is a 3C curve type. Okay, so we have in this option a right thoracic scoliosis confirmed by the forward bending test, and we did the X-ray and we confirmed that there is a true thoracic scoliosis. The pelvis is shifted to the thoracic concavity, so we have a 3C type. Okay, the second type is the 4C type, where we ask the same question and we follow the same in all curve types. If there is a structural thoracic scoliosis, we do the forward bending test. Okay, when we do the forward bending test, if we found a very mild, even a mild hump, a very mild hump or rotation, we then confirm with our radiological examination and X-rays to see if there is actual true rotation of the vertebra or not. Okay, so the second question, where is the pelvis in relation to the trunk? If we have the pelvis is to the right of the thoracic curve, for example, here, if there is a right thoracic scoliosis, okay, and the pelvis is also shifted to the thoracic convexity, it means that this type is 4C. So this is the definition: 3C type, structural thoracic scoliosis, pelvis shifted to the thoracic concavity. 4C type, structural thoracic scoliosis, pelvis shifted to the thoracic convexity. And then the other curve type that we ask the same questions. Do we have a structural thoracic scoliosis? Yes or no? If yes, I have here a hump. Okay, so where is the pelvis? If the pelvis is symmetrical, it means that I cannot see any shift either to the left or to the right. It means that this type, curve type, is called non-3, non-4 type. Okay, if the answer of my first question was no, it means that I don't have a structural thoracic scoliosis. So I will ask myself, do I have a lumbar or thoracolumbar curve? If yes, I have a lumbar or thoracolumbar curve, it means that this curve type is called single lumbar or single thoracolumbar type. Usually in the single curves, we can allow an overcorrection, but we have this plus or minus. We will talk the second type, the minus. It's mainly about the degenerative scoliosis. Okay. Now we will talk about the plus sign. Okay. The plus, it means we give it when we do an overcorrection of the main curve in some or all exercises. And to make it easier for you during the classification, we give you a hint about which is the main curve in each curve type. For example, in the 3C type, the main curve in here is the thoracic curve. So when we ask ourselves, can we do an overcorrection to the main curve? We're asking ourselves, the main curve is the thoracic here in 3C type. Okay? In 4C type, the main curve will be the lumbar or the thoracolumbar curve. Okay? The non-3, non-4, the major curve or the main curve is the thoracic, and the SL-STL, the major or the main curve is the lumbar or thoracolumbar. Okay? So the plus sign, overcorrection of the main curve in some or all exercises. The minus, no overcorrection in any curve in all exercises. Okay? Here is this S, the S letter, the structure proximal thoracic. When the apex T5 and above, it means that I can have in any curve type, either 3C, 4C, non-3, non-4, or SL, STL, I can have an S type or proximal thoracic scoliosis. Okay. Here is it shows the X-rays that is related to the above curve types, which all together having like 8 curve types. The first is the 3C plus. We have first is the structure thoracic scoliosis. We have in the forward bending test, we have a hump. And on the X-ray, we have the main curve is the structural thoracic curve. Okay. Are we going to give him a plus sign? If we are going to give him a plus sign, okay, it means that I have, 1 second. If I'm going to give him a plus sign, it means that I can have a very minor lumbar curve, or I cannot have a lumbar curve at all. Like this X-ray. It will show in the next, I will show you in the next slides. So the first question, is there a structural thoracic curve? Yes. Where is the pelvis in relation to the trunk in the frontal plane? If the pelvis was on the thoracic concavity, it means that I have a 3C type with the main is the thoracic. Okay. I want to give him either a plus or sign. Can I do an overcorrection allowed for the main curve? If yes, if I will give it a 3C plus, it means that I have a minor lumbar curve, or I don't have a minor lumbar, or I don't have a lumbar curve. If no, it means that I have the structural thoracic scoliosis. The pelvis is shifted to the thoracic concavity. The main curve, I cannot do overcorrection to the main curve because now I have a significant lumbar curve that will, if I did an overcorrection to the main curve, it will be affected. That's why we give it a 3C minus. Okay, the same goes with other curve types. For example, for the 4C type, the main curve is the lumbar or thoracolumbar. Okay, so we ask ourselves the same 3 questions. Is there a structural thoracic curve? Yes. The pelvis in relation to the trunk. In case of the 4C type, we have the pelvis on the thoracic convexity. What is my main curve? The main curve is the lumbar or thoracolumbar. So can I do an overcorrection for the main curve? So if I'm asking myself, can I do overcorrection for the main curve? I need to look at the other curves in the X-rays. If I have a minor thoracic curve in the X-ray with the main curve lumbar or thoracolumbar, it means that I can give this type plus sign, and I can do an overcorrection for my main curve without affecting the minor thoracic curve. If I cannot do this, it means that I have a significant thoracic curve, so I give it a 4C minus. It means that I have my main lumbar or thoracolumbar curve, and I have a significant thoracic curve above that if I apply the overcorrection to my main curve, the significant thoracic curve might be worsened. The same goes with the non-3, non-4 type, with the structural thoracic scoliosis, pelvis symmetrical, with the main thoracic. My main curve is the thoracic. Okay, if I'm having a non-3, non-4 plus, it means that I don't have a lumbar curve or I have a minor curve. If I have it non-3, non-4 minus, it means that I have a significant lumbar curve. The last curve type, I don't have a structural thoracic scoliosis, so my question will be, is there a structural lumbar or thoracolumbar curve? If yes, so I will give it as SL or STL type, with my main curve is the lumbar or thoracolumbar. If it's plus, it's the normal, because usually in adolescence we have not many structural changes in the vertebra, but that's why we give most of the patients a plus sign, unless we see something that makes us decide that it's a minus, or we give the SL-STL in case of the degenerative or adult scoliosis. Okay, now we will talk about the 3C plus. Can you see this? Okay. No problem. The 3C plus, okay, we have here the presentation of, I'm asking myself, is there a structural thoracic scoliosis? Yes, I have a right structural thoracic scoliosis. I did my forward bending test and I have a right hump. I did the X-ray, and my main curve now is the thoracic curve. There is vertebra rotation, the pedicle is rotated, okay? Now, where is the pelvis in relation to the trunk? The pelvis in relation to the curve, or the main curve, now is shifted to the thoracic concavity. When the pelvis is shifted to the thoracic concavity, it means that this curve type is 3C. I haven't yet decided if it's a plus or minus, okay? When I want to decide if it's a plus or minus, I want to follow the criteria that we described in the first slides. The clinical criteria, the radiological criteria, and the prognostic criteria. For example, if in the clinical criteria here, during the forward bending test, I have only a hump at the thoracic side, and I don't have any hump on the lumbar, or a very minor degrees of angle of trunk rotation, very minor degrees that is measured by the scoliometer. Okay? Then I check my radiological criteria. I'll check the X-rays. I can see that there is a complete curve of the thoracic. Complete curve means that there is tilted upper end vertebra and tilted lower end vertebra. Okay, so this is a complete curve of the thoracic. I look to decide if it's a plus, can I do overcorrection or not, or minus? I need to check the other curves. Now I will check the lumbar. We can see that the lumbar, that we don't have a complete curve. So I have an upper end vertebra, but not complete lower end vertebra. Second, I don't have a big rotation of the pedicles. I don't have a wedging of the vertebra or deformation. And even when I measure the cup angle, it's not that much big. Okay, so collecting all of these criteria together, it leads to the conclusion that this curve is minor lumbar, or even I don't have a lumbar, so I give it the 3C plus sign. The 3C plus, it means that I can do an overcorrection to my main curve, which is the thoracic curve. Okay? Now, the 3C minus. Can you see the difference between the 3C plus and the 3C minus? We'll follow the same questions. Do we have a structural thoracic scoliosis? Yes. I will confirm by looking at the forward bending test, and I check the hump. Second, where is the pelvis in relation to the trunk? You see the difference between the first picture with the 3C plus and the 3C minus. The 3C plus, the pelvis looks more shifted compared to this curve. This looks more symmetrical, although it's still shifted to the thoracic convexity, but it's here the asymmetry is more than the 3C minus. Why? Because in this curve type, when I do the forward bending test, now I have a minor or a measurable angle of trunk rotation on the lumbar curve. It means that there is a little more rotation to the lumbar vertebra compared to the 3C plus. So the answer to the questions, I have a structural thoracic curve, and this is the hump, and I have a minor hump on the lumbar side. Still, the pelvis is shifted to the thoracic concavity. Okay? I will look on the X-ray and I will collect my clinical, radiological, and prognostic criteria to know if this curve is significant or not, in order to decide that if I can do overcorrection to the main curve. Now, if you see in the X-ray here in the 3C minus that we have the complete curve that is shown with an upper end vertebra and lower end vertebra to the lumbar curve. Second, we have a hump clinically that is shown. Third, we have a pelvic tilt that we discussed in the radiological criteria, with the pelvis is more down on that side. We have slight rotation, and we have also slight wedging of the vertebra. All of these criteria, it means that if I did an overcorrection to the main or thoracic curve, it means that I might worsen this curve type. And this is very important in our classification system, because if we treated all patients having a 3C with the pelvis shifted to the thoracic concavity with the same concept, it means that some patients will get better, but if I did overcorrection to all of the patients, if I'm having a significant lumbar curve, it means that this curve will worsen. Okay? So in 3C plus, definitely we have a lumbar curve. That's why we give it the minus sign, because we cannot do an overcorrection to my main curve, which is the thoracic curve. Okay? Next is the 4C. The 4C, we ask ourselves the same questions. Do we have a structural thoracic scoliosis? Yes. In order to classify a 4C type, we need to have a thoracic curve, even if my main curve was the lumbar or thoracolumbar, but we need to have a thoracic curve. Otherwise, it would be called SL or STL type. So for the 4C, yes, we have a structural thoracic scoliosis. It may be apparent or it may be not. And if we want to confirm, we need to use all of our assessment tools, like using the scoliometer during the forward bending test, using the X-rays and checking the pedicles and checking the cup angle. Okay, so yes, we have the structural thoracic scoliosis. Now the second question: where is the pelvis in relation to the trunk? Here, the pelvis is shifted at the same side of the thoracic convexity. So that means that it's a 4C type. Now we need to check the X-ray to know if I can do overcorrection to my main curve, which is the lumbar or thoracolumbar. Can I do overcorrection to the main curve, which this curve? Yes or no? To answer if yes, I can do overcorrection, I need to look at the thoracic curve. If I have a minor thoracic curve that I cannot see a big rotation, only 2 to 3 degrees clinically measured by the angle of trunk rotation, and also in the X-ray, it is complete curve, but it's not so significant. We have a mild rotation, no wedging, very small cup angle. So we decided to choose this curve type as 4C+. It means that I have a structural thoracic scoliosis, like presented here in the schema of blocks. I have a structural lumbar or thoracolumbar curve, which is the main curve. The other type is the 4C-, which we can ask ourselves the same questions. Is there a structural thoracic scoliosis? Yes, we have a structural thoracic scoliosis, and the hump is seen here clinically on the patient. The second, where is the pelvis in relation to the trunk? If the pelvis is shifted to the thoracic convexity, it means that this curve type is a 4C. How we can say that it's plus or minus? If it's plus, we check the X-rays, and we check clinically, here we can see that there is a hump in the thoracic and a hump on the lumbar. Checking on the X-ray, yes, we have the main curve, which is the lumbar or thoracolumbar curve, but look at the X-ray on the thoracic curve. Can we do an overcorrection to my main curve, which is the lumbar or thoracolumbar? If definitely this curve is significant, and we cannot do overcorrection to this curve, because if I did overcorrection to this curve, the lumbar or thoracolumbar, it means that the significant thoracic curve will worsen. That's why we call this 4C minus, because we cannot do overcorrection to my main curve, which is the lumbar or thoracolumbar. I don't want you to misunderstand me that we don't do overcorrection. It means that we don't do correction. We do perfect three-dimensional correction to the all curve types, starting from the 3C plus or minus till the SL-STL, but we allow the overcorrection, like doing a more lateral flexion and more maximum correction to the main curve only on the plus types. The third curve type is the non-3, non-4 type. We ask the same questions. Is there a structural thoracic scoliosis? Yes. Where is the pelvis in relation to the trunk? Now, when you see the patient clinically, you can see that the pelvis somehow is in the middle. I cannot see any deviation. And also, if I'm not sure that this curve type is exactly symmetrical, you can also check the X-rays. We have a radiological criteria like the transitional point in relation to the central sacral line to confirm if the pelvis in the midline or not. In this curve type, yes, I have a structural thoracic scoliosis, and yes, my thoracic curve is the main curve. Now I will look to the other curve. If I don't have a hump, or I'm having a very minor hump during the forward bending test at the lumbar, also checking the X-ray, I don't have a big rotation, I don't have wedging, the cup angle is small, I don't have for example, the research stages, the research stage is 4, it's not 0, for example. So all of these criteria combined together give me the indication that this curve type, the minor lumbar or no lumbar at all, it means that it's not significant, and I can do an overcorrection for this curve type, for the non-3, non-4 plus. It means that I have a structural thoracic scoliosis is the main curve, and I don't have lumbar, or I have a very minor lumbar. How about the non-3, non-4 minus? The minus means that my main curve, of course, my main curve it will be significant, but also the other curve will be significant as well. So I have a structural thoracic scoliosis. Yes, it's the main curve. Second, the pelvis in the midline. Third, when I look at the X-rays, can I do overcorrection now to the main curve, which is the thoracic? Of course, I cannot do an overcorrection to the main curve because I have now a significant lumbar or thoracolumbar curve. So having a significant curve, though the patient looks really balanced, it means that sometimes we don't only depend on the clinical pictures. We need to combine all of the assessment criteria in order to reach to the correct classification type. This is for you to avoid the future mistakes, to avoid getting into dilemmas, either to correct this or not to correct this, and to get the best possible correction from the beginning. So this curve type definitely will be non-3, non-4 minus. I cannot do overcorrection to my main curve, which is the thoracic, because I have now a lumbar, a significant lumbar curve that if I did an overcorrection to my main curve, that will definitely worse. The last curve type, which is the single lumbar or single thoracolumbar, I asked myself also the same questions. If I did the forward bending test and I don't see any hump at the thoracic, I need to confirm with the clinical, with the radiological or the X-rays. If I see like this X-ray that the curve is in the lumbar or the thoracolumbar side, it means that this curve is single lumbar or single thoracolumbar. Now, I need to, now when you look here at the forward bending test, if you didn't look at the X-rays, you might think that this might be a thoracic. So we need just for this this curve type to confirm radiologically that my apex is like, if it's a thoracolumbar, it's T12 or L1, or it's lumbar, it's below L1. But you can see here the hump because you have a rotation. It goes up until even the thoracic curve. So this rotation, it's not because it's a thoracic curve, it's because we have a significant lumbar or thoracolumbar curve, and still the above vertebra is still rotated, so it looks clinically like it is a thoracic curve. So here in the STL-SL plus, we have no structural thoracic scoliosis. We have structural lumbar or thoracolumbar scoliosis. In a patient adolescent, we don't have pain issues. We don't have any abnormalities in the vertebra. We don't have any deformation or degeneration. So we can definitely allow to the overcorrection. What about this curve type? STL-SL minus. Now, yes, we don't have a structural thoracic scoliosis, and we have a structural lumbar or thoracolumbar, but can we do overcorrection to a curve that is like degenerated? The patient complains of pain, maybe he has disc issues and so on. So in this curve type, we don't allow overcorrection, though it is a single curve. Okay. Thank you so much. I hope that it was clear, and sorry for the disruption at the beginning of the lecture. Thank you.
Perfect. Thanks to all of you for these nice and interesting presentations. We can now open up the discussion part. We already have some questions from the Chinese participants, so I will read them. Please feel free to submit any question that you have on the Q&A section or in the chat. Or I don't know, even if you can just raise your hand and maybe we can unmute you to open your microphone. So just to make a brief conclusion before we go to the discussion about what Sarah presented for you, because this was a quite intensive lecture about our classification. In total, we have 8 different types for scoliosis. And for every curve type, we apply some specific exercises based on the curve type classification. And you will have some extra information about how we apply these techniques from a lecture later on from Burcin. So let me read some of the questions that we already have from the Chinese participants. First question, if we can explain the difference between traditional Schroth training and Schroth training methods that you are currently exposed to, such as Schroth best practice or Schroth ISST. So to give you an answer for this question, because it's not a very short answer, but I try to make it as short as possible. The initial technique that was described by Katerina and Krista Schroth a little bit more than 100 years ago was in use for many, many years. And at that times, this method proved to have very good results. However, as you can understand, the times change by years and it's not possible anymore, for example, to do a very intensive program like 4 or 6 months, like it was at the beginning in the Katerina and Krista Schroth technique, or later on like 1 month intensive training. So there should be some adaptations. There are also new scientific data that came up, and every method should be adapted to these changes. Now, obviously, between all these techniques, including also us and best practice and ISST or Barcelona school, we have, let's say, common origins. There are some principles of correction that were described by Katerina and Krista Schroth, and some of them, they are included in all these techniques. But now all these methods that were described, including us, we have a different classification system, and this makes a huge difference between the two, between the different approaches, because based on the classification, we have different application of the exercises. And then there is also a different concept of correction. One of the main differences, for example, is that there are some schools like the best practice and the ISST that they focus, let's say, a little bit more on the major curve and they do overcorrection for the major, what they consider as major curve in every exercise. So they are, let's say, a little bit more aggressive in the corrections. There is the BSPTS on the other hand, that is a little bit more conservative in terms of overcorrection. So they don't do overcorrection, they don't do lateral flexion. So for us, a difference between these approaches is that we have the term of selective overcorrection that was explained to you by Sarah. It means that based on some criteria that we use, we can decide which curve type can be overcorrected. So it's not that we always overcorrect or we never overcorrect. It can be something in between. And this is what we represent in terms of correction. And of course, when you decide that you overcorrect, then as a therapist, you have the opportunity to decide how much overcorrection is needed. Because if you do it too much, there is a problem of risking compensations to the secondary curve, and sometimes it matters a lot. If you don't do overcorrection, you miss the opportunity to get the maximum of correction for your scoliosis, and this should be the aim. I hope that by this I can just briefly explain some of the differences. Obviously, all the techniques have proven to be effective, so it doesn't mean that we claim that we are the best. I think maybe one advantage that we have is that this technique was developed by me after being educated and practicing for many years, getting quite good experience from all the other techniques, because I had my education in all the other techniques. So maybe what we can claim is not to be the best, but we have tried to fill the gaps that were created by other techniques. That's all. There is another question from the Chinese group about the term of overcorrection. And this was mentioned in the context of nighttime brace applications. When implementing PSSE therapies like Schroth method for AAS, a 3D corrective exercises emphasizing positional adjustments in all three planes. And the question is, if we apply overcorrection, one concern is how to maintain coronal plane balance during training. And if we should require the child's head and neck to remain strictly aligned with the spine throughout the exercises. So this is a more technical question, but I have to give an answer. I know some of the people in the audience, you are not familiar at all, but I need to answer every question that you give to us. So the concept of overcorrection does not always mean only lateral flexion, but lateral flexion can give you the maximum of overcorrection. And this is exactly the concept that is applied in the nighttime braces when they get into these lateral flexion positions. So you said about the concern on how to maintain the coronal plane balance. I will tell you what is our concept. As you probably noticed from Sarah's presentation, in our school, we have two different types of exercises, and we are the only school that we have the discrimination. We have the normal exercises that in all these, and these are the vast majority of our exercises, during them, everything is perfectly balanced, not only in coronal plane, but in all three planes. We have a second type of exercises that we call them overcorrective. And these overcorrective exercises cannot be applied in every curve type. So what we do is we apply selectively the overcorrection in the curve types that is not dangerous to have a compensation and is beneficial because you can get the maximum of correction. And as I said, this should always be the main aim. For the position of the head that you asked in your question, I will tell you that, of course, we have to take care about the position of the neck, avoiding creating a compensation in the proximal thoracic region. So this is why we do some corrections for the shoulder block, as it is called in Schroth technique. So the upper part of the body, including the shoulder, the neck, and the head, to be well aligned. And in case that we have a structural proximal thoracic scoliosis, we have some specific techniques that we have developed to adjust all the corrections and bring everything into perfect balance. Another question from our Zoom group. In what degree range of curves so we can say that it is significant? Okay, if I understand your question from Asmi, it means that your question is how you can understand if the curve is significant or not. I will tell you, we have some criteria as it was presented, clinical, radiological, and prognostic. So our idea is to avoid taking wrong decisions. You have to analyze all these criteria. And as a specialized physiotherapist in the field, you have to do this analysis for establishing prognosis, for making your treatment plan. So you need to make a global assessment. So the assessment is not only the angle of scoliosis. Obviously, the angle is one of the most important, but not the only. So you have to take all the criteria from the medical history, the clinical assessment, the radiological analysis, the prognostic analysis, and you put them all together to decide if one curve is clearly more significant than the other, or if you have double or balanced curves. As you can probably understand, when you have more double and balanced scoliosis, we almost always avoid overcorrection because this is risky to create compensation. So overcorrection is allowed when you have a single curve or you have one clearly major curve. I can understand that sometimes this decision, even for the people that are educated in our school, can be really tricky because you might be in a dilemma to decide, can I overcorrect or not overcorrect? We still have the answer for you. Because the way that we educate you is if you are in this position, because you will have to be many times in your clinical practice, you have two options. One option is go with the safer way. If you feel insecure about doing overcorrection, classify minus. You will get a perfect 3D correction in every exercise. If you are still thinking about, yes, but maybe I can do some overcorrection, please feel free to do this selectively. Selective overcorrection for us means that if you decide to classify a curve type as plus, doing some overcorrection, then maybe you can say you do some overcorrective exercises, 1 or 2 of them, 1-2 days per week, not more. And if you come to our courses, you will realize that we pay too much attention on the clinical monitoring and follow-up of the patient because this will give you the answers if you decided properly or not. So if you decided to overcorrect a curve type that normally is not a good decision, then even if you do a mistake, you will have the opportunity with a proper clinical follow-up to change your mistake and do the proper classification and the proper exercises for your patient. So this is the answer to your question. There is another question from the China group that there is a feeling from these participants that our classification is more detailed compared to BSPTS. I don't know if you are already certified in BSPTS, the one that you ask this question. So for patients that classified as 3C plus and 3C minus, aside from the emphasis on overcorrection and pelvic adjustments, are the training methods the same between these two subtypes? No, there are some differences. Also on the application of the exercises. So it is true that my main background is coming from BSPTS because I used to be a teacher for BSPTS for 5 years. So I know this technique even better than all the others that I was educated. So my feeling was that in BSPTS, the classification was just 3C, 4C, non-3, non-4, and SLSTL. So just these 4 main categories. But by practicing and by getting experience, my feeling was that this was not enough to describe all curve types. So there were some 3Cs that you can overcorrect, but some others that you cannot overcorrect. Same for 4C. There were some curve types based on their characteristics that you could overcorrect safely and selectively, but some others that you don't overcorrect. So this is what I personally consider as an advancement in the field, okay? We have a few more questions. I don't want to run out of time. So will the patient be educated to do PSSE daily at home? Yes, but the daily is depending on the prognosis. So there are some patients that you can ask them do the exercises every day because the risk for progression is very high, especially during the peak of growth. And there are some others with better prognosis that they don't have to do it daily at home. So every time what you have to do is an individualized assessment, establishing prognosis, and then based on this prognosis, you can prescribe the treatment plan for them. So sometimes it can be more intensive, some other types, it can be less intensive. And one last question, I know you have many, but then we have to continue our lectures, and we'll have time at the end of the webinar to discuss if something is coming up to you. Please feel free to send any question. So Papa Maria is asking, if scoliosis recovery begins during the growth period, 12 to 13 years, and the child already had scoliosis since the age of 9, but the parents did nothing until then, what is the probability of helping correct the scoliosis so late and avoiding surgery? If I understand well your question, I think that you speak for a early diagnosis at the age of 9, but late start of treatment at the age of 12 or 13. This is something that is related again to what I explained just a few seconds ago. You always have to make an individualized assessment. So sometimes if you see that the patient has a potential to progress, you might need to intervene at an earlier age, because the problem is that the time is always against us. So if the patient is during growth, scoliosis can progress, sometimes less rapidly, some other times more rapidly. Unfortunately, it happens quite frequently that although we have early detection, we don't have a proper intervention at that time. And many times the doctors, they say, all right, just observation, come back in 6 months or 1 month or 1 year. And then we have a progression, and we have to start at a later stage. So the earlier that you start, the best the possibilities to avoid progression or to improve scoliosis, and of course to avoid an operation. Okay, so thank you for these questions. Now I have to give the word again back to my colleagues and to Burcin to go a little bit more on the practical part, explaining to you the principles of correction and presenting some exercises with her patients. So, Burcin.
Thank you, Nikos. Did you see my screen in both application? For both, right? Okay, great. Yes, now we are talking about 3D principles of correction that we use in PSSE-Schroth. These are the 3D principles of correction we use in PSSE-Schroth. And I just give you the general idea how we treat our patient and which principles we should follow. First of all, we have 3D autocorrection, which includes self-elongation, pelvic correction, asymmetrical and symmetrical sagittal straightening, and frontal plane correction. 3D autocorrection means putting everything in a correction, putting everything in best possible 3D alignment. And it should be 3D, so we have correction for sagittal, correction for transversal, and correction for frontal plane. And second, we have corrective rotational breathing. After putting everything in a correction, you need to expand the collapse area, because if you have scoliosis, you have some collapsed area, because scoliosis is a deformity of the trunk and the spine as well. So you have some collapsing area, and you need to decollapse this collapse area. You need to expand this collapse area. So you need to work with some breathing technique. And it should be 3D, why we call it rotational breathing. And the third one is muscle activation. You need to activate muscle in correction. And we have 3 strategies for that. First of all, keeping expansion while exhaling. If you try to keep expansion while exhaling, you already activate and quite a lot. And our second strategy, it comes from original Schroth method. It's based on original Schroth method, and we call it tension. It is shoulder traction, thoracic counter traction, or shoulder counter traction. And the last strategy for muscle activation is pressure. Pressure means if you want to increase activation, you need to externalize. For example, it can be a wall bar, it can be a chair, it can be a TheraBand, it could be everything to increase activation. And the last one for the principles, 3D principles, is stabilization. And this is really important part. It means training of activities daily living. And it means when your patient finish the exercise, they need to stabilize the correction and implement on daily life. This is really important because we want to decrease, we want to prevent asymmetric loading during daily life. Yes, I give you my example just to explain these little better. You can see the patient pelvis is shifted to the left and trunk is shifted to the right. And you can see the X-ray and you can see the thoracic hump on the thoracic convexity. And what is the 3D correction? What is the 3D principles of correction? First of all, we have 3D autocorrection, which means putting everything, as you see, putting everything in a correction. When you check this patient on stance, her pelvis is shifted to the left and her trunk shifted to the right. But during Schroth session, during exercise, her pelvis and trunk should be balanced because 3D autocorrection means putting everything in a best possible 3D alignment, and this is really important. And the next one, next principles is breathing, rotational breathing or corrective breathing. You need to expand the collapse. You need to expand collapse area. You need to decollapse collapse area because you have some collapse area here and also here, and you need to expand here to get more correction, to get more expansion. You need to work with some specific breathing technique. And the last one, third one is muscle activation. You need to activate in correction, and you can use everything to increase correction, which is called pressure. I use stick, you can use chair, you can use TheraBand, you can use everything. And the last principle was stabilization. I don't have any stabilization picture for now, but I can tell you that the stabilization is really, really important because we need to give some specific recommendation for the patient according to the curve type. How to sit, how to stand, how to lie down, on which side, what to avoid. These are really important to prevent asymmetric loading during daily life. Because we can say that actual treatment happens when your patient finish exercise, because it is the ability of keeping the whole correction during daily life. And you can see the overcorrection exercise here. And as you can see, during the overcorrection exercise, the patient looks exactly the opposite of her normal state. Her pelvis in overcorrective exercise shifted to the left and her trunk shifted to the right. But in her normal state, her pelvis shifted to the left and her trunk shifted to the right. It's the opposite of her normal state. And this is the example for stabilization. You can see the patient with spinal fusion surgery, and she's still out of balance. Her pelvis, as you can see, shifted to right side and her trunk shifted to left side. But I want to give you this example because maybe this is helpful for you you can understand better how we teach our patients, recommendate. For example, how to sit this patient, how to stand, how to lie down, which side, or what to avoid in daily life. This is really important, and these are whole concept behind 3D principles. Yes, this is end of my presentation. Now I give the words Nikos again to start his own lecture again.
Hello, thank you, Burcin. Now I'm sharing my screen, and I hope that now all of you can see my screen normally. Okay, so let me minimize them. All right. So we have a little bit discussion about the bracing and how the bracing can be used in general, and then how our classification is used in bracing design. So first of all, for the brace, we always need to have a 3D correction. The brace is actually doing what is doing passively what we are trying to do actively with our exercises. So there should be a compatibility. We have in the brace the 3-point systems for alignment in the frontal plane. We have pair of forces for regional derotation in the transversal plane. And we also need to keep a good balance and alignment in the sagittal plane by normalizing kyphosis and lordosis. There are some types of brace, like the asymmetric synod-type braces, that are more compatible with what we do with PSSE-Schroth exercises and in general with scoliosis-specific exercises. For the frontal plane correction, here you see a patient with double scoliosis, right thoracic, left lumbar curve. And you can probably see the asymmetries of the patient on the pelvis, which is shifted to the right, is higher on the right side. You can see that the right shoulder is higher than the left. You can probably see the differences between the trunk and the arms. This area is more collapsed because this is the concavity of the curve, and this is the convexity. So what we want to do in the frontal plane is actually to apply some forces in the proper areas to put the spine, the pelvis, the whole trunk in the best possible alignment. So we need to correct the pelvis from right to left. We need to correct the left lumbar curve to the right, and always going to the cranial direction, because we always need elongation. We correct the thoracic curve, and we also need to rebalance the shoulders. These should be the pressures in the brace, and this is exactly what we had in this brace design for this patient, and we got a very nice correction of the curve in the brace, bringing everything into balance in the frontal plane. We usually say that an acceptable in-brace correction is approximately 30% of reduction in the brace, which means if we have a curve of 30 degrees in the brace, this curve should go close to 20 or even less. However, this is related to many other factors. Of course, it's much easier to get this 30% of correction when you treat a curve of 27 degrees compared to a curve of 45 or 50 or 60 degrees. Second, of course, every curve has its own rigidity, and it's not always easy to get this amount. But the idea should be to get the maximum of correction of the angle, and the brace to be comfortable for the patient to be worn. But it's not only about the frontal plane, because scoliosis is a 3-dimensional deformity. So here, what you see in the frontal plane, except from the pressure zones that are already here with the arrows, we also have some expansion rooms. So the expansion rooms are exactly the areas that During exercises, we're going to use our hands on the patient, saying, breathe in to expand the collapsed area. So we speak mainly about concavities, and you see how the concavities are described on the X-ray, and also how these expansion rooms are applied in the brace. Now, the transversal plane correction is very important. So we need to create some pair of forces to derotate. And this is why in the brace, we use some extra pads in the proper areas to increase the corrective forces. And what you can see here, for example, for the thoracic part, is that we have a posterior lateral pad to correct both frontal and transversal plane. And at the same time, we need a force on the prominent rib in the front to create these pair of forces to derotate. And here I think that you can see it even better, because imagine that what you see here is the spine from a top view. So like you're looking at the spine from the top to have all 3 dimensions. And this is a transversal cut of the rib cage. So the rib cage is not just shifted and rotated, at the same time is deformed, is distorted. So we have a deformation of the ribs on the concavity, but also on the convexity as well. And here you can see a right thoracic scoliosis. So if you understand where the pads are positioned in the brace, we have these areas that the pads are applied on the convexity and on the prominent rib to create these pair of forces for derotation. So these areas in the brace, they have full contact, and there is no chance to get an expansion during breathing in the brace. This means that we create in the brace some expansion rooms, so on the thoracic concavity and on the area in front of the thoracic hump, we call it ventral flat zone. So when the patient is just normally breathing in the brace, the effect that we have is that this area is moving forward and this area is moving backward and outward. So even a single normal breathing in a correct brace design, it can be a corrective breathing. Of course, what we can train our patients is to work even more with that, with the corrective breathing that are educated by our exercises, to get more expansion, to give more volume to the rib cage. And this is the way how we create this internal pair of forces for derotating and getting a partial correction of the structural scoliotic flat back. So the pads, as you will see here in this patient, are applied obviously on the convexities. So we have the pads for the thoracic hump. We have the pads for the lumbar hump. Also, if needed, pads for the pelvis, the prominent pelvis. And in the front, we also use pads for the ventral rib hump. The reduction of the angle is very important, as we said, and we need to have a 30% of in-brace correction to say that the brace is properly fitted on the patient. Sometimes with a good brace design, you can have a result like this. So you can have a correction of more than 60 or 70%. The more the correction, the better the prognosis. But we also need the compliance of the patient. Don't forget about that. If the patient is not wearing the brace the required amount of time, then you are not going to have a good result with them. But as I said, on the X-ray, there is not only the angle that you have to measure, you also have to check the axial rotation, the rotation of the vertebra. I'm not going to analyze this too much, but just for your information, we analyze and we measure the rotation of the vertebra by the position of the pedicles on the X-ray. So you can see where the pedicles were. When the pedicle is shifted more to the midline, it means that we have more rotation. And you can see how the pedicles are in the brace. So a good brace should take care both frontal plane, transversal plane, but also sagittal plane. And sagittal plane is extremely important to be normalized. And as you see here, we have a normal lordosis, normal kyphosis in a well-fitted brace on this patient. Now, I will briefly present you some of the brace designs that we had for some of our patients. The classification was described by Sarah before. So we have the 3C plus type, and you see the correction of this patient on the X-ray. But I can tell you, even before you have the in-brace X-ray, because we usually ask for this X-ray to be taken 4 to 6 weeks after the first fitting, you can understand just by taking photos of the patient without the brace and in the brace, the amount of correction that you get and how the patient is much, much better balanced in the brace. So for this patient, having these photos with the initial brace fit, I was already 100% sure that we will get a nice in-brace correction. This is a 3C minus patient with a structural lumbar curve that we didn't decide to do overcorrection, and you see now the imbalance of the trunk and the pelvis is not that much, and also there is a significant rotation of the lumbar curve. So you see from 36 degrees for the thoracic, we went in the brace to 13, and from 32, we went to 16 in the lumbar. This is a 4C plus patient with a major lumbar or thoracolumbar curve and a minor structural thoracic. You see 45 degrees of thoracolumbar, 25 degrees of thoracic, and in the brace, we got a perfect correction for the major curve, the thoracolumbar, from 54 to 60, so from 45, sorry, to 6 degrees, and almost 50% of correction for the thoracic. This is a 4C minus patient, double major scoliosis, balanced curves, no chance for overcorrection, 34 degrees thoracic, 37 degrees lumbar, and in the brace, we got almost 100% of correction for the lumbar and 60% of correction for the thoracic. Norm 3, Norm 4 plus. This is a curve type with the pelvis balanced and a major thoracic curve. In this case, we had a 35 degrees of thoracic, and you see that in the brace, we got a very nice reduction going down to 14 degrees without affecting in a negative way the lumbar. This is the idea of our classification. This is the idea of our principles of correction for exercises, but also for bracing. So the idea is not to overcorrect to the maximum the main curve by creating compensations to the lumbar or to the secondary curve. And as you can understand, we apply the same principles of correction for the exercises into the brace design. This is a patient with a Norm 3, Norm 4 minus case, which means right thoracic, left lumbar, more balanced curve. We decided in this case to avoid overcorrection. And as you can see, we got a very nice in-brace correction from 30 to 13 and from 21 to 8. And you can see that for every curve type, the brace design is different. Now we have closed pelvis because the pelvis was already well balanced from the beginning. And this is the single lumbar or thoracolumbar plus type, STL or SL plus, with 41 degrees of thoracolumbar, left thoracolumbar curve. And in the brace, we brought it down to 11 degrees. And you can see just immediately after the brace fitting, how much the patient is corrected in the frontal plane. Of course, also the sagittal plane alignment and the correction of the rotation is very important. Now, I will continue with my lecture, giving you a little bit more information about the international scientific societies and what are the guidelines. There was a lecture by Georgiana at the beginning, so I will be very short on that. PSSE are always the first step in scoliosis treatment, and the main aim is to stop progression. This is always the main aim. Of course, sometimes you can get some partial correction or improvement of the angle and the clinical and radiological aspects, but the main aim is always to avoid progression and, if possible, to avoid bracing. When we speak for scoliosis below 25 degrees, that we start to work exclusively with exercises. All these scientific societies in their statements and their guidelines, they say that there is a scientific evidence that PSSE are superior to general or no exercises, and that recent high quality studies have proven PSSE efficacy in reducing the likelihood of progression. And we also have very good evidence that the brace, together with scoliosis specific exercises, is better with brace without scoliosis specific exercises. These are the guidelines, but I would like to shortly present to you what is the evidence for our school, what is the evidence for what we do. And this is a prospective control study from our clinic. This was also in the social awards in 2023 for the meeting in Melbourne, in Australia. We had 221 patients, one of the largest among the published literature, 163. They did PSSE-Schroth exercises, 58 were the control group with general or no exercises. Our inclusion criteria, angle between 15 to 25, research 0 to 2, rotation more than 5 degrees, less than 1 year post-menstruation. So we had a group with a real potential of progression. At the peak of growth, more than 15 degrees, which means high potential to progress. The success rate, so avoiding progression, was 87.1% in the PSSE group, only 26% in the control group. We also got an improvement of the angle more than 5 degrees in approximately 25% of our patients. And if you see the brace prescription rate, it was only 10% for our PSSE group and 67% for the control group. We also found improvement of aesthetics and quality of life, which is also very, very important for the patients. And in conclusion, the application of our exercises with the PSSE-Schroth method can be effective to reduce the risk of progression at the peak of growth in mild scoliosis. And we also got this improvement of trunk rotation, body symmetry, and quality of life. This is another study from our group combining brace and PSSE-Schroth exercises. We had 102 patients. We used the SRS inclusion criteria, so patients with 25 to 40 degrees at the peak of growth. And the result was the success rate, 88.5%, again, one of the highest in the published literature. And similarly to our previous study, almost 1 out of 4 patients, they got not only stabilization, but improvement of their scoliosis more than 5 degrees, and only 6% overpassed the surgical indication range above 40 degrees. So it seems that the combination of brace and our exercises can effectively treat scoliosis at the riskiest period during the peak of growth. Obviously, the most important prognostic factors are in brace correction and compliance. And now I would like to share some of the results that we have in our clinic by applying the method. And I start with mild scoliosis below 25 degrees. That we did only exercises. The main aim in these cases is to stop progression and avoid or delay bracing. So you see that we got a very nice improvement from 20 to 7 degrees. In this case, from 23 to 9 degrees. In this double scoliosis with 18 and 20 degrees, we got a reduction going to 17 and 12 degrees doing only exercises without bracing. From this scoliosis 18 and 22 degrees, we went down to 13 and 14. And in all these cases, you can see also the improvement on the clinical image of the patient and also the trunk rotation. This was a case with 25 degrees. We had a very nice reduction, went down to 10 degrees, and you can see on the right bottom side the improvement of the vertebra rotation, and you can see on the photos how much better her clinical balance is. Another category of patients that we can treat exclusively with exercises is when they are at a later growth stage with a curve even more than 25 degrees, we can still work only with exercises, but at a late growth stage, not at the peak of growth. So look at this double scoliosis with 31 and 34 degrees, went down to 22 and 20, and also a very nice improvement on her clinical image. Another case, 30 degrees, reserve for late growth. We did only exercises and we went down to 13. And again, here you can see the clinical improvement and also the improvement of the vertebra rotation on the X-ray. Another category that you can work only with exercises is adult scoliosis, because in adults, we don't have brace indication. This was a lady with a right thoracic scoliosis 41 degrees. We went down to 36 and look at the improvement that we got on the trunk rotation, on the clinical aspect of the body symmetry for her. And also, many times here, we have to treat pain because adult scoliosis can be many times painful. Like in this case, that she came with a lot of pain, 53 degrees of scoliosis. The doctor recommended an operation. We did only exercises. We reduced the curve to 46 degrees, and we also got reduction of the pain, improvement of aesthetics, and avoiding an operation for her. This is an extraordinary correction in a lady of 38 years old when she came to our clinic with 73 degrees of scoliosis, having steady progression as adult. And we managed very well to improve the pain, the aesthetics, and also bringing her curve down to 55 degrees almost 2 years after treatment. But when we have scoliosis above 25 degrees during growth, of course, is not only for doing exercise. We have brace and exercises together, and you can see here some of the examples that we got a very nice treatment result. Like in this case, from 32 and 33 degrees, we went down to 16 and 8 degrees. From 30 to 16 and 36 to 23, look at also the clinical improvement on these patients. Even in more severe scoliosis, above 40 degrees, we can have a very successful treatment outcome with a proper treatment with brace and PSSE-Schroth exercises, like with this girl from Albania, from 31 to 11 and from 41 to 16. And this X-ray is out of brace for at least 24 to 48 hours. This is the in-brace X-ray, so you can see how significantly this curve was corrected in the brace. The patient was compliant with brace and exercises, and we got a perfect treatment result for her. Another person that was recommended for an operation, having a curve more than 40 degrees, from 45, we went down to 34. Another one, from 48, we went down to 39. And look at also the improvement of the trunk rotation in this patient and the body balance. Or even more severe cases like this one, from 67 degrees, we went down to 56 degrees. And look at again the improvement on the patient clinical balance and body symmetry, from 65 to 47 degrees. So all severe scoliosis that were recommended for operation, but we managed very well not only to avoid progression, not only to avoid an operation, but to give a very significant improvement for these patients. And 1, 2 examples for some more special cases like neuromuscular scoliosis. Look at this patient with a cerebral palsy. She was prescribed an operation for her, 45 degrees. You can see the in-brace correction went down to 12 in the brace, and we got a very nice improvement of the angle in this case. Or this, again, extraordinary case with a spine schwannoma, so a tumor of the spine, and a very aggressive scoliosis at the age of 10. He already had 74 degrees. Look at the in-brace X-ray, 26 degrees in the brace, and final result, 25 degrees less. In this case, with a very, very severe and aggressive scoliosis. Thank you for your attention. By the way, on this slide, you can see also our social media accounts and our websites and our emails if you want to contact us for more details. And by the way, I would like to tell you that in the next days, the full recording of the webinar will be uploaded on our website. So you can have access if you missed a part, that you can attend it again. Now I give the word to my colleagues to continue. Please feel free to submit your questions.
Hello again, Nikos. It's my part now.
Let me check a little bit the agenda that we have. Yeah, so it's the educational plan. And then we have the conclusions, okay?
Yeah, perfect. Just a second to share screen on both application. Okay. And this one. Just to check, I'm on both applications now. Nikos? Perfect. Okay. Because I haven't seen you. Perfect. Okay. Now I will talk about educational plan for our method, PSSE-Schroth by Nikos Karavidas. So to start applying this method, you need 9 days. 3 days is for basic course, 6 days is for level 1 course, but for final certification, we need 15 days. Also includes 6 days of level 2 course. Our course include high quality of theoretical education, like clinical assessment, and we have a lot of evaluation tools, prognosis, radiological measurements, pathomechanism of progression. And in the end, when the patients finished basic and level 1, they will receive from us a unique patient evaluation form for clinical and radiological assessment of patients with scoliosis and kyphosis, which is developed by Nikos, and it has 6 pages. So you have a lot and all the details, information that you need to store with your patient. Our basic course, it lasts 3 days, and it can be online with instructor live by Zoom or in person. This basic course includes theoretical education. We are talking about epidemiology, etiopathogenesis, prognosis, about hyperkyphosis, Shorman disease, and scoliosis. Also includes scientific data and treatment indication for scoliosis and kyphosis, clinical, radiological evaluation of scoliosis and hyperkyphosis. Then we talk about PSSE-Schroth curve type classification, and we introduce the 3D principle of correction for our method. But then you have to do the level 1 course to apply this method. Level 1 course, it lasts 6 days. It includes 3D principle of correction for PSSE-Schroth, practical educations for scoliosis and hyperkyphosis. Practice is between therapists. Why? Because you need to feel as a therapist and you have to be able to do this exercise. Then you can explain to your patients. At the end, we have a written exam and our participants get a certificate, so here they can apply the method. They can work with scoliosis no matter of the type curve or kyphosis. And then they can attend our level 2 no matter the time, whenever they want. They don't have time restriction. After level 1 course, it's coming level 2 course that it lasts again 6 days. But here we have advanced exercises for kyphosis and scoliosis. Here we have practice every day with real patients under instructor supervision. So we will evaluate our patients every day. We will treat them clinically, radiologically, and then applying these exercises. It includes case-based analysis for treatment decision and practical approach. We will talk about special scoliosis cases like congenital, neuromuscular, syndromic, adult scoliosis, post-operative scoliosis. We will talk about braces and biomechanics for scoliosis and kyphosis. And then the end, we'll have a practical exam with real patients. We'll have patient, you have to do the evaluation and then treat it, and we will talk at the end about this practice. After level 2, participants will get the final certification of PSSE-Schroth method. We have also an optional course, is the master course. It lasts 4 days. Here we have practice every day with real patients, case-based analysis for treatment decision and practical approach. We will talk about other PSSE schools, advanced knowledge for brace biomechanics, surgical options for scoliosis and kyphosis, spinal fusion and non-fusion techniques, research methodology and updating scientific data. And At practice, we will have also modified exercises for kyphosis and scoliosis based on Pilates, yoga, TRX. Here are all our instructors from our method and the chair of our method, the chair of PSSE-Schroth methods. And here it's our upcoming courses in Asia. We'll have soon courses in New Delhi, India, in Shanghai, China, Bangor, Indonesia, and in Dubai. And here are the countries where we have at the moment education, but more are coming. We are really happy that our method is all over the world, even though we started the first PSSE course in February 2023. We have in 2 years a lot of certified therapists. Thank you for attending our webinar. Now I will give the word to Sarah to finish this webinar.
Thank you, Georgiana. As we wrap up today's webinar, I want to thank you all for your time and engagement. We have explored the conservative treatment of scoliosis. We delved in the history of the Schroth method. We said about an introduction to the PSSE-Schroth method and why to be educated in the PSSE-Schroth method. We have talked about the PSSE-Schroth classification and how to implement the principles of correction in the exercises. Also, we have talked about the PSSE-Schroth classification for bracing, the scientific evidence and the treatment results, and the educational plan and future courses. Finally, we have touched on providing opportunities for the continuous learning. I hope this webinar has been informative and valuable for you, and if you have any further questions, you can reach out anytime. Thank you again for your participation and looking forward to see you in our future courses all over the world. Thank you so much. Now will be the discussion with Nikos to answer all of your questions. Thank you.
Thank you, Sarah. Thanks, everyone, for still being here with us. And please submit if you have any questions, either on the chat or on the QA section. There is a question on Zoom from Sumaya Singh, if we have worked on scoliosis along with rotation. Obviously, as I mentioned in my presentation for bracing, but also like what my colleagues said during their lectures, we have always to work in 3 dimensions. And scoliosis is always coming in 3 dimensions from torsion, which means that all the corrections should be applied in all planes together. This is what we do. So you cannot, let's say, separate the correction saying that, okay, now I will work on the frontal plane and then I will focus on rotation. So every exercise has a derotational component together with the frontal plane correction and the sagittal plane alignment. And these same principles of correction are applied not only in the exercises, but also in the brace design. There is another question from Rim on Zoom. How long does it take to have significant aesthetic improvement? This is not something that you can predefine. First of all, we need to understand something, that the main aim always is to avoid progression. So if you avoid progression in an otherwise potentially progressive scoliosis, you already have a good result. Many times you can get improvement in radiological aspect, reducing the angle of scoliosis, also clinically, aesthetics, body symmetry, trunk rotation, quality of life, and so on. But this is not something that, as I said, you can predefine. The way that we measure all these things is by the proper clinical follow-up. So you will be advised by us on a monthly, more or less, basis to repeat some clinical and just give me 1 second. I think my mic. 1 second. Do you listen to me now? Yes, okay. Sorry for the interruption. As I said, it's not something that can be predefined, but you have to regularly do the clinical measurements to be able to detect if you have signs of improvement, and it seems that you are going very well, or if you have signs of progression, because sometimes you have to understand that. Okay. Now, can you hear me on Zoom? Okay, all right. Sorry. So I will repeat the last part. The question was how many times does it usually take to see an improvement clinically on the patient? And the answer is that it's not predefined, but you have to repeat some clinical measurements on a monthly basis to reevaluate if the patient is going well or not. And sometimes you can see this even from the first weeks, from the first month. So you can measure the rotation with the scoliometer and you can find a reduction. You can check and compare the initial photos with the next photos that you take, and you can see an improvement of the body balance, the body symmetry, the position of the shoulders, the pelvis, or you can have improvement of pain sometimes, even from the first weeks. But of course, is something that is going to the long term, because you need to keep applying the exercises based on the risk of progression, based on prognosis, on the growth stage of the patient. So you cannot predefine. So please, my advice is don't promise that you will be more straight in 1 month or 3 months or 6 months. Don't do that. What you can say is by applying properly the exercises, you can have greater possibilities not only to stabilize scoliosis and avoid progression, but also to get some reduction. And as you saw, I think we presented to you so many good treatment results, even when you work only with exercises in more mild scoliosis or combination with bracing in moderate or more severe cases. There is another question on the chat from Rim again. Are PSSE recommended after surgery, or we should do only stabilization exercises? That's a good question. I will tell you. Of course, you can apply, and I think you must, not only you must apply scoliosis-specific exercises after every operation, no matter if it is a spinal fusion or non-fusion technique, because you need to have a kind of rehabilitation after any operation. And you have to understand that even with a successful spinal fusion, scoliosis is not disappeared. So there are still some loads on the spine, and you need to train the patient how to unload their spine. You need to train them for the activities of daily living, or you need to control the non-fused areas when we speak about spinal fusion. When we speak about the newest techniques with non-fusion, like the vertebral body tethering or ApiFix or these systems, I think that the role of the scoliosis-specific exercises is important to enhance the growth modulation that is taking place through these techniques, and again, to improve the final outcome and bring the patient into the best possible clinical balance as well. And it is very, very important. Obviously, you have to do it a little bit more carefully. There are some rules that we follow when we treat patients post-operatively, and always don't forget that you need the permission from the doctor in these cases. So don't start doing something without the permission of the doctor, because you might create damage to the patient, and also you might be blamed that if something went wrong after the operation, your exercises could be blamed for that. So always in contact with the doctor, but definitely I would recommend for every operation to have scoliosis-specific exercises afterwards. I think that we have no more question and we are well on time. We just passed 6-7 minutes from the initial plan of 2 hours. I would like at this point to thank all of you for your contribution, my colleagues, Georgiana, Sarah, Burcin, our local organizers in China, Indonesia, and India, and Dubai, that we are going to have our next courses very soon there. Of course, I would like to thank you, the audience, that you spend your Saturday with us, 2 hours of your Saturday. So I hope you also enjoyed this lecture. Feel free to contact us at any time on our website, on our social media, or our email accounts to answer any question that you have. And take care. Have a nice weekend. Thank you for being with us. Bye-bye to everyone.